So one of the things, if you think about health policy in the United States and you think about the problems we face and you grab any random health policymaker in Washington or anywhere and you say, what are the problems of American healthcare? They all say, costs, quality, access. Great. And then if you ask them, what about other countries? How do they do it? The general answer in Washington is everybody else has got this figured out. People have figured this out, and the number of times I've heard we spend more and get less out of our healthcare system than anybody else is nominally true, but like actually not that interesting way of thinking about the problem. And so for years, there has been work on comparative health systems. And there was a whole generation of scholars, Mark Roberts, Bill Shao, a whole group of folks who studied health systems and really tried to understand what was going on. And that work has sort of faded for a while. And the Commonwealth Fund has carried on the flag of that through these surveys that they do. But I would say about 5, 6 years ago, an absolutely extraordinary, I can say young because she's younger than me, scholar at the London School of Economics really started doing what I thought was the most innovative work in this area, which was going beyond input, going beyond how many doctors do you have, how many nurses do you have, how many hospital beds do you have, to starting to think about what does care and delivery look like across health systems. Beginning to ask questions like, if you fall and break your hip in Boston versus London versus Berlin versus Toronto, what happens to you in the days and weeks that follow? What are the implications for costs? What are the implications for quality? What are the implications for outcomes? And a whole set of work that has, I think, begun to give us a whole new set of insights into how health systems are actually working and how health systems are struggling. And this center really tries to get, in my view, at the heart of that question of how can we all learn from each other and how can we all do better? Because the answer is not that everybody else has figured it out and America has not. And I think you'll get a feel for that. So today's event is really a chance to delve into that. And before I introduce the person who's gonna kind of get us started, there is a 2-minute video that I'm hoping somebody will play because I don't know how to play that video.
Hello everybody, my name is Astrid and I'm a postdoc at the Centre for Health System Sustainability. Today I'm very happy that we are launching our centre, and to kick off this centre launch we actually want to get the people's perspective from Rhode Island and ask around what they think is currently the biggest issue with our healthcare system and what they would do to change it. Come along with me.
Among the many things, the biggest issue for me is the cost and then the lack of transparency.
Healthcare is completely unaffordable without a job.
If we had a better chance to actually be able to improve our healthcare system, speed it up a little bit, get people in and out of hospitals, and create a better image for the hospitals, maybe a lot of people look forward into getting their healthcare done and taking into consideration that the hospital would be the safest place for you.
How accessible healthcare is currently. I think there's a lot of barriers of knowledge where if you don't know what you need, it's very hard to get the right tests or see the right people.
It doesn't apply for everyone. That's a major problem with me. I mean, I'm French. We have a system over there. It's not perfect, but at least everyone's covered.
Very specifically in Rhode Island, I feel like the state doesn't really do a lot to invest in opportunities to keep medical talent here so that we have facilities and infrastructure some of the time, and we don't really have the personnel to keep it all running. Basically, affordability and access. What would I change? I mean, it has to come through tax policy.
More universal health care.
Try to get rid of some bias that's in there, like women not being listened to with their pain, or like people who are obese or overweight just being told to lose weight. I think improving that could go a long way.
Prices should be just displayed, it should be published, it should be a fixed cost regardless of the insurance or what insurance you have or what plan you have.
All right. So I'm going to ask our next speaker, Martha Wofford, to come up. And when we were organizing this event and we were trying to think about who would we want to frame what the health policy challenges, healthcare delivery challenges are in the state of Rhode Island, but really as a kind of a benchmark for how to think about the challenges that U.S. faces, we really couldn't think of anybody else that we would rather have, and so we were thrilled that Martha can do this. She is the president and CEO of Blue Cross Blue Shield. Before this job, she was at DaVita, really the largest dialysis company in the country, and oversaw the shift from sort of volume-based to value-based care, has worked at the White House, has really had a fabulous career already, and has brought a lot of perspectives to the national scene, to the work that is happening in Rhode Island. So without further ado, Martha Wofford.
Thank you, Dean Jha. It's great to be here. It's a real honor. I think this is very much needed, this new center. Of course, you already sort of framed the conversation because you can't talk about healthcare policy in the US without those three major areas, right? So I'm going to talk to you a little bit about affordability or cost, access, and quality. And I'm going to go a little heavier on affordability because we got lots going on here in Rhode Island that's kind of interesting. It's great to connect the policy side as well as the payer and provider side for me, so I'm really glad to be here. And I would just say, before we get into it, I think that COVID represented not just an existential threat to our health, but also to our healthcare system, and it really ushered in a new era of fragility in particularly the economics of our hospitals and other providers here in Rhode Island and nationally. And we're still working really hard to get our providers on good financial footing here in Rhode Island, so it's something that there are very close partners and we work very hard at. So let's talk a little bit about affordability. You heard from the interviewees that affordability is a top concern, maybe the top concern. And today, healthcare costs consume a lot of the dollars for employers. So the majority for our international guests here of Americans are covered through their employers. And what happens is, as healthcare costs go up, the cost to cover healthcare replaces wage growth. And so you have some stagnation historically in wage growth. Now, the last couple of years have looked a little different as the unions have won some big battles nationally. We've seen a battle for talent. But in general, that's something that happens. It also is true that healthcare spending tends to crowd out other types of spending in our budgets at the state and federal level. It's now 29% of our federal budget that we spend on healthcare, which is a lot. I would say there's a lot more spending on the horizon. We're at this amazing moment in terms of technological advances in healthcare. I think if anybody had said to us, hey, we're going to be able to take somebody's genes out and modify them and put them back, and it's going to completely cure a disease, our minds would have been blown. But all that's happened in the past, 5-10 years has really been phenomenal. However, it's outpacing our ability to pay for it. We don't have payment mechanisms that cover treatments that are curative that may cost $4.25 million for a single dose. We just don't. If you're a small employer, you do not have the wherewithal to pay that bill. And a lot of these diseases that are being treated are childhood diseases, which means that it disproportionately hits Medicaid, which is underfunded. So we have a structural challenge. And I would say, again, I'm so excited about what cell and gene therapy, as an example, represents for the people who have those rare diseases, and so terrified for the people who are on the hook to pay for them. We just don't have a mechanism. I personally find myself in a lot of debates about GLP-1s right now. I don't know if everybody else does. And I was actually with the ICER folks last week and looking at the cost, and they would say, well, it's just that they're overpriced, there's a lot of value. And obviously diabetes, obesity are huge public health threats. And so if we can find, Americans love to take pills, right? We don't really like to change behavior. And so the idea that we could actually address these really big public health threats is, on the one hand, exciting. On the other hand, I think only 35% of people are staying on those drugs at current benchmark a year in. And so you don't actually get the public health benefit, you just get the cost. And so I'm skeptical, seeing a huge rise in cancer here in the state of Rhode Island, as we are nationally, of younger people. And so I think we have to look at, again, as she said, I was working at the White House in the Clinton administration. I also worked at the Environmental Protection Agency and at USAID. And so when I think a lot about the pesticides and that we tried to regulate and looked at some of the toxicity reports early on, it's really evident that you have to think of pesticides as cumulative in the human body, not as the single thing you're eating. And so that's not how our regulatory framework works. And so I don't know what the cause is. I don't think anybody knows yet of the increase in things like aggressive forms of cancer for younger people, but I think there's a lot that is coming. The other thing, besides the fact that probably how we're eating and what we're eating is driving a lot of these conditions, it's all cancer included. The thing about the pricing of the GLP-1s is super frustrating because we have some guests from France. So does anybody know what the average price of GLP-1 is in the United States per person, roughly? Anybody? $1,000. Good job, Mandy. Do you know what it is in France? No. Anybody? It's $83. So, I don't think it's news to you, Ashish, that we Americans are paying for drug discovery globally, but that is the reality. And if you ask a drug company why the pricing is different, they say, well, Americans will pay it, and other people won't. So somehow we have to figure out how to stop paying for it. The other thing I would say is that specialty drugs in general are driving this huge spike increase. So we've seen a 42% increase in the cost over the last 5 years of a compound annual growth rate of specialty pharmacy. Unsustainable for us. I would say the Inflation Reduction Act, which lets the government negotiate on behalf of the top 10 drugs for the Medicare volume, is a turning point. It's really important win against the pharma lobby, which is incredibly powerful. And we've seen in the last couple of weeks the first uptick in the biosimilar usage that we've seen. So all of the companies that tried to block those from coming to market, the IRA is actually unlocking the adoption now of some of the biosimilars, which is super exciting. So again, a lot to be hopeful about. Here in Rhode Island, I'm just going to turn a little bit to the local situation. We have done a pretty good job managing healthcare cost growth. We have a hospital rate cap, which sets the amount that we can't go above to pay a hospital, which certainly helps in negotiations. I think I saw Andy Ryan, I don't know. There he is, sitting next to his lovely wife. I think you guys are working on a paper that would say, hey, and that's also hurt some of the hospitals, right? So yes, you've kept prices lower and cost growth lower, but the hospitals are fragile. So one of the things that we did is we, Blue Cross Blue Shield of Rhode Island, along with big hospital systems in Rhode Island, got together and funded, I won't even call it a study, it was a report of publicly available information to pull together into one place to say, let's be fact-based. Let's stop with the anecdotes of people go over the border and get paid more. What's the data say? And what the data showed is that on a Medicare relativity basis, Rhode Island hospitals are reimbursed on par with our neighboring states, between Massachusetts and Connecticut. So that was good. Now, on an absolute basis, it's not. It's lower, because Medicare adjusts for cost of living. But I would note that here in Rhode Island, our household income is 19% lower than it is in Massachusetts. We are a poorer state. People get paid less. There's less dollars available to pay for healthcare. So on a relative basis of how much of your paycheck goes to healthcare, it's more in Rhode Island. So anyway, I just share that because it's important to bring data. I think that's a lot about what happens here at the Brown School of Public Health to these important debates and try to figure out what do we then do about them. The other thing it uncovered, which again may not be news to all of us, but put it all in one place, is that here in Rhode Island, we have many more people who are covered by government programs than in our neighboring states. And so we have more people as a percentage on Medicaid, more on Medicare, which means that the smaller proportion of commercial members have to pay and subsidize the other areas. And so we just don't have that many of us to pay more for commercial insurance. And it uncovered we really need to raise the Medicaid reimbursement rate. It's very, very low. And it's so low we actually leave federal dollars on the table because we're not hitting our levels for a federal match. So a lot of opportunity to improve the healthcare system and the funding. If we all get together, we see the data, we can then push for policy changes. Okay, went a little deep on affordability. I'll go quick on access. I would just say, and I know, John, you worked on the Affordable Care Act, and it was just an incredible step forward for this country. All right, I'm going to do another little quiz. Can anybody here guess what the rate of the uninsured in the state of Rhode Island is? Does anybody know? Irene? 3%. Okay, so that Frenchman said everybody's covered in France. We're pretty darn close to everybody being covered, and that's a huge change over the last 10 years, right? I mean, it has fundamentally changed, and so we should be incredibly proud of that. Medicaid is not as good coverage as commercial. It's a little bit of a two-tier system in terms of your access to specialists, so we just have to acknowledge that it's not perfect where we are, but it's a heck of a lot better than it was. Another person said, oh my God, it's impossible to know where to get care and what to do. It's so hard to navigate the healthcare system. Different issues here in the US than abroad. Here, it's really up to the patient to stitch together the information from one provider to the next. Multiple tests get done on the same person, often because nobody's connecting that data, and it's really hard for people to figure out what to do. Primary care, absolutely foundational to managing a population. We need a thriving primary care set of providers and system here in Rhode Island, and it's actually pretty good. We talk a lot about being frustrated with getting access. We're top 5 in the country. It may not feel good, but it's on a relative basis, it's better than most parts of the country, which is interesting when you actually, again, bring the data to bear. Now, I would say, we also have a lot of physicians that are near retirement, so we can't sit here and say it's good. What we have to do is invest in primary care. And so that's something that we take super seriously at Blue Cross. We've invested over $500 million outside of reimbursement to try to bolster, over the last 10 years, to try to bolster primary care and help them really thrive. And I would say one of the biggest practices here, Coastal had their best recruiting year ever, just hired 21 new physicians. So, and that was because we pay them differently now. We pay them in capitation, which means at the beginning of every month, they get paid for every single patient that's in their roster, whether they see them or not. So that has driven a huge shift in their ability to pay people more. Certainly when we saw COVID and people couldn't come in through the doors of primary care offices, they really struggled. So knowing you're gonna get that payment no matter what is really important to primary care practices thriving. So really proud of that work, but there's so much more to do. It's not to say we're there, it's just to say we're working really hard and trying to help practices shift to team-based care. So it's not just about the physician, it's about the nurse practitioner and the social worker and the dietitian and everybody coming together to better manage a population. And so we need to get to the point where these practices can take on more patients and we can improve access. And so that's where what we're working on really hard now. Another key issue is access to specialists. We don't have enough, even though I know they're paid at a much higher rate. We have higher utilization than other states in the nation and in the region. We have an older population, and we have a high chronic disease burden, which is true nationally, I mean, and globally. I just think we're gonna see more and more. People are living a lot longer without the resources to pay for their health care, and they're living longer unhealthy. And so we just have a big opportunity. And we need to get to the root cause of disease and not just, I think, take pills to try to address it. We're also really, really bad at end-of-life care here. I think there's lots of countries in Europe that are far better about how do you actually help people age in place in communities, what do you do at the end of life, and how do you have those conversations and help people die with dignity. Okay, lastly, quality. I'm sure Irene probably has good insights for us about how that could work better. So quality, and again, this is probably the quickest portion here because unfortunately there's no real owner of quality in the United States. We think of it as the government keeping tabs on the quality and reporting on it, but in the reality is that they don't really have the capacity and bandwidth to mind the store. So we have bad actors that play. There's a huge story about Steward hospitals up in Massachusetts and nationally that have just taken a whole bunch of money out of the hospitals and given that money to private equity and other entities and not invested in the people and the facilities. So that happens. It's not just private equity. It happens. You can have bad actors on the nonprofit side as well as on the for-profit. But right now, we just don't have regulators who are holding people accountable for quality. And a component of quality is equity. And we have a problem with health equity in the country. And here in Rhode Island, we work with the Brown School of Public Health to field a study that measures how Rhode Islanders perceive social determinants of health, things like affordable housing and access to food, access to healthcare, and it just keeps getting worse. So we've been doing it 5 years, and the data just continues to deteriorate, even though we've got a community of people working hard to address it. And I think what David Williams said when we did that launch was very insightful, just to say we have a income inequality issue, and that so much of the healthcare challenges we're having are really issues with structural racism and mostly with economics. And we got to find ways to invest in underserved communities. So I think that's such wise words. We'd spend a lot of energy at Blue Cross on investing in affordable housing and trying to really work on intergenerational wealth transfer through housing and trying to spur entrepreneurship in underserved communities so that we can try to get better jobs and which lead to better healthcare ultimately. So I guess those were the things. I don't know if this is helpful to the discussion you're going to have. That's what we're facing here in Rhode Island. I do really believe in laying out the data so that we can all come together to figure out what are the policy interventions to address them. And again, now that I laid out the problems, hopefully you guys can solve them. And I feel so incredibly fortunate here in Rhode Island to have Dean Jha, to have the Brown School of Public Health, to partner with, to try to bring data to these really hard problems, try to make progress in a fact-based, policy-oriented manner. And I'm so excited to have the Center for Health System Sustainability join that conversation. So thank you.
All right, Martha, thank you. So why don't I invite our panelists up to the stage. Sorry. I think I will sit here. So here's what we're going to do, just in terms of format. I have some questions. So I'm going to ask them each to introduce themselves. They can do a better job than I can. Then we're going to get into some questions. We're going to go for, half hour, 40 minutes. And then we'll open up to questions from the audience. And so I'm going to start off to my right. Luca, do you want to tell us a little bit about yourself, your background, what brings you here outside of Irene asked you to come? And then actually, while you're introducing, I will just ask the first question that maybe you can get into at that point, which is, why do you think international comparisons are interesting and useful, since you have worked quite extensively at them? You want to use this?
Yeah, you mind?
No, it's fine.
It's much easier.
Do that.
I can bring it.
Okay. No, I got it, please.
Thank you. So, good afternoon, everybody. I'm Luca Lorenzoni. I work at the Organization for Economic Cooperation and Development, which is an international multilateral organization based in Paris, in France. There are 38 member countries at the OECD, so we had the opportunity to just discuss policy questions with so many different and complex health systems. So international comparison, it's really our bread and butter, I would say. And so I strongly believe that we can learn from each other. But to learn from each other, to learn from different systems, we have to put the questions right, first of all. And then we need to have data to try to provide some responses to those questions. And then we can eventually inform policy, take policy action, which means that whatever we think about, whatever kind of results, insight we bring to the table, they should be actionable. So they should reflect something which could really make a change into a complex systems like the health system. So when you think about the OECD, you think about comparing, I don't know, the Republic of Korea, one single national health insurance system, very low prices for health because they negotiate prices with providers organization, but on the other hand, high volume, high utilization. You compare to a system like Italy, a national health system, it's based on residency, so it's financed through tax contribution, and you get 21 regions within Italy, very different one from the other. So it's not only about comparing countries, it's also across countries, it's also about comparing within countries. Because, for example, in Italy, but also if I think about Canada, if I think about Australia, we got systems which are regionally based. So when you hear about Rhode Island, Massachusetts, Connecticut, you got the same in Italy on a smaller scale. Think about the north, the center, and the south. My contribution, it's about data. So it's our job. So what you need is a coordinating organization which starts by agreeing on some indicators, which could be, as I say, useful for policy comparison. Think about the fact that, for example, we just say, oh, the US spends a lot on health. It's about 17% of GDP, which is spent on health, as compared to the OECD average, which is 9.2%, 2022. Behind these numbers, there is a huge amount of work, which is based on what? On valid indicators, how you report to a coordinating agency, which could be the OECD, but could be also WHO, or could be your center, Irini. And then you agree with experts in each country on how to prepare data, send data to you, how to validate data, and how to report those data in a way that is available to the general public. So even if we're talking about a small, simple number, 17% of GDP as compared to 9.2% of GDP across OECD countries, US versus OECD, behind this there is a book, the System of Health Accounts, Guidelines, Manual, 400 pages. There is, in each country, there is at least one team of experts that every year send the data to OECD. We got a team to validate the data and to report the data and to improve, because it's not just the indicator, it's also what is actionable, what could inform policy, which means we keep on refining the indicators because we should be able to provide responses to policy questions which evolve over time, I would say. And this is a process which takes time, which is transparent, and which needs really a kind of legitimacy on the end of the coordinating agency. So countries should recognize this coordinating agency so that they can share, they can send data that then can be used by policies, which means by the public also, to go back in your country and say, oh, this is how we compare to OECD average. This is how, for example, in Korea, we compare to Japan, to Australia, to another country. It's very powerful. So we inform the policy debate, and we think that our role is really to make those indicators as useful as possible and in a dynamic way, I would say. Which means that today we're trying to answer, for example, this question about how much you spend on health, but tomorrow it's how much we spend on long-term care, for example, which is a huge challenge. Think about long-term care. Think about how the different systems cover long-term care services. There is no safety net in the US, for example, as to long-term care services, I may say, whereas there is an insurance for long-term care in Korea, in Germany, in the Netherlands. So when you compare across countries long-term care spending, is it related to health? Is it related to social? You just touch upon social determinants of health. It's so important. So I think that this role of the OECD is really to harmonize data collection and to try to provide useful answers through valid indicators to policy questions which are different depending on the moment, depending on the political interest. And so I think my role there is to facilitate this project. I'm part of the team which works very much on health spending, health prices, projections. So what will happen in the future in terms of sustainability, which could be also fiscal sustainability. So can we cope for the future needs of our aging population? And so I'm part of this team, which is really much, I would say, on the expenditure side. And I'm happy to be here today to just try to contribute to this debate. Again, we don't have that many answers, and I'm aware of that. So, but still, I think that could be useful to have some ideas which could guide our discussion today. So thank you for the invitation.
Luca, thank you. And before we go to Jonathan, I will just say that a few insights. Look, I think OECD better than any other organization. Not to suggest any other. Hey, I know. Sorry. Except for WHO Europe, of course, and the observatory, which does extraordinary work. Anyway, OECD more than any other organization, I think, on an international comparisons basis, has set the kind of gold standard. And it is a reminder that data is very powerful. But here's the trick, right? Like, whenever you put out data on any topic, if you don't like what the data is telling you, the first thing people say is, the data's wrong. And no one generally says that about OECD data, because the amount of work and the amount of validation that goes into creating OECD data is extraordinary. I had a little experience with this many years ago when I worked on how do you measure electronic health records across countries. Like 3 years of work, because everybody measures these things differently. And harmonizing, ultimately what the power of the OECD is it builds legitimacy into data, and that is what drives policy. So Luca, you and your team have been just doing extraordinary work on this and is extremely helpful to us. All right, the second most important organization, I'm kidding, Jonathan, to you. A little bit about yourself and then this question.
I think, do I use this?
Yeah, I think it should work.
We'll see what happens. So thank you for inviting me. So I have two roles, actually. So half of me is the head of the London hubs of the European Observatory on Health Systems and Policies, this second best organization Ashish speaks of. So the observatory is a partnership. It's hosted by the World Health Organization, which supports evidence-based policymaking in European countries, and most of its partners are countries in Europe. So this is half of me. The other half of me is the senior economist in the WHO Barcelona Office on Health Systems Financing. There I work exclusively on health financing with also countries in Europe. The work is much more country-based, I would say. It's much more countries come to us with a particular challenge, and they want to work with WHO to sort of see what other options countries are exploring or whether countries are facing these common challenges, or they need political support trying to think through what's a rational approach to their problem. Oftentimes, the ones that are looking for political support are the ones that have the worst solutions in mind. So a lot of the work that we do, I would say, is preventing really bad ideas from happening. So these are my two roles. And before I came, so I've been working at the observatory since 2010. So before that, as Martha was saying, I worked for CMS in Baltimore. I'm from Baltimore originally. This is not a Barcelona accent. And so I worked for the Office of the Actuary at the Centers for Medicare and Medicaid Services on projections of health spending and modeling of costs during Obamacare, the Obamacare discussions before it was Obamacare, or before it was the Affordable Care Act. And I was relatively recently out of college and very naive and very frustrated. So I would stay at work every day during this time till like 11 o'clock at night. So we would get, text legislation from Congress that would be some sort of proposal, and I was working on the team that was, all right, turn this into a model. And it was a really fun puzzle, and I would stay way late for a government employee at my cubicle, and then go home and see on TV that some congressman had said, we're definitely not doing that on the news. And I was really disillusioned, and actually, Ashish, as you said at the beginning, I had that mentality of like, surely in Europe they do it better. And they must listen to evidence, and they just, pull out all of the latest studies on whatever the topic is, and they synthesize this, and whatever the literature says, that's what they do. So I was like, I'm getting the hell out.
Telling us that's not true.
I didn't say that. No, well. No, I mean, this was my thinking, at least. This was my motivation for wanting to leave Baltimore, as great a city as Baltimore is. And what I found, is that it's a little bit better. Like, countries are smaller in Europe. So in WHO, in the European region, there's 53 member states. So anything that you think of from Rhode Island as being Europe is probably Europe, but also there's a lot more, clearly. So anything that used to be the Soviet Union that's not our official way of describing it, but it's how I explain it to my mom, is part of the European region. And so a lot of those countries don't have the capacity to deal with problems on their own. So they really do come to WHO or the observatory for suggestions and for their policy problems. And as I was saying, a lot of times the challenge really is that policymakers are by and large not academics. And there's a saying that we use a lot of times, that to a man with a hammer, everything looks like a nail. And this is oftentimes the case, that there'll be a new minister in Kazakhstan, and they've heard about medical savings accounts, and they gotta have them. And they don't care about what problem they're trying to solve. They don't care about the fact that nobody could possibly pay into a medical savings account in Kazakhstan. They want to see, they've heard about them, and they've got to have it. And so a lot of times, the work that we do, and this relates to the comparative work as well, is really about sort of helping policymakers, sort of bringing them back down to earth. I wouldn't say it to them like that either, but sort of bringing them the evidence, coming as an unbiased, I have no stakes in what happens in Kazakhstan or in Ireland or wherever I'm working. So we come from a very objective perspective about bringing the evidence, helping them think through the challenges that they face. Now, in terms of like what I think international comparisons bring to this discussion, other than all of this, is I think that a lot of times countries also sort of think within their own countries. Policymakers think within their own country context. So, using a specific example, countries that have social health insurance systems, right? A lot of them historically have thought, okay, we want to progress towards a universal population coverage. We want everyone to be covered, but if you don't pay your contributions, like, I'm not paying for you, right? I'm not, my grandmother's not paying your healthcare if you're not paying your contributions. And they get stuck in this sort of loop of even if they have common objectives like universal health coverage or universal population health coverage, they struggle to think outside of their own sort of constraints that they've created within their system. And so a lot of times comparisons, not so much on the data side, like Luca was talking about, but on the policy side, it's about saying, okay, Bulgaria, Belgium, you're not alone, right? You're not the only countries that are facing these challenges, and countries take all sorts of approaches to, using a specific example, to expand coverage to people who are not making payments. So, of course, many of these countries have contributions from the treasury or the equivalent in their country on behalf of poor people or pensioners or people like that, there's plenty of people that fall through the cracks. And so a lot of our work will say, okay, well, if you look at a country like France, where you live but are not from, France is traditionally a social health insurance type of system. It used to be that you paid your contributions, and as a result of paying your contributions, you had coverage. They wanted to expand coverage 20 years ago, but they couldn't get past this idea of social contributions. Contributions are the key to unlocking coverage. So what do? They changed from a social contribution-based system to an income tax system. Everyone's paying income tax, and if you're not paying income tax, it's not like the health insurance funds are not tax agencies, right? So you make this change, which it looks like a revenue-based type of change, but actually it's very strong justification for saying, okay, let's de-link this idea of paying contributions and entitlement. All this is to say that these ideas don't just come from nowhere, right? So it's really useful to have this sort of laboratory of global experiences that face these challenges, and to be able to sort of do this pattern recognition and say, okay, well, this looks a lot like this challenge here, but they've dealt with this in maybe this way that you wouldn't have thought about naturally. So to me, that's the value of international comparisons.
I love it. So the comparisons of data, comparisons of policy. Let me turn to our last panelist, last but certainly not least, Irene Papanikolaou. So a little bit about you, but also why start a whole center on health system comparison, health system sustainability?
So I guess I'm coming at this as the researcher in the room, but I've been very fortunate always to be kind of on the border of where I think research and policy are, and have enjoyed very much speaking with my colleagues from international organizations and researchers in other countries, and always kind of trying to understand what are the issues that are going on. And that's always kind of motivated me in my research. Even when I started out doing research in one country, it was the UK, which is, I guess, one of those countries that's many countries, and it was devolution had just happened, and it was this exciting time where in the UK, England, Wales, Scotland, Northern Ireland kind of could deviate in how they design their systems, and I thought this was fascinating. You're going from a country, like 4 countries that had the same system to being able to do things differently, and wanted to understand, well, what are they going to do differently? What impact does it have? And slowly this turned into an interest in going beyond those 4 countries. And always what's fascinated me is that you have countries that have similar objectives when you think of what health systems are trying to do. They're trying to improve people's health, trying to deliver care to people that's responsive to their personal needs, and treat them with respect and dignity. Do this in a way that doesn't break the bank or take money out of all of the other areas that the government needs to invest in, and be equitable. At the same time, they face similar challenges. In the entire world, we have a population that's aging. We have increasing multimorbidity. We have new innovative treatments that systems are struggling to pay for. We have new challenges that are global, pandemics, climate change. And yet we do so little to learn from one another. Like, as John said, we have this laboratory of hundreds of case studies, more if you think of systems within systems, so regional systems. All of these policymakers struggling with the same solutions, and that we don't have the data to really understand what do these different choices result in? How do populations think about trade-offs to make? How much do I invest in improving care for some at the expense of care for all, or how much is the optimal amount to invest in the health system as opposed to other areas of public expenditure? And yet we have all this data and missed opportunity that we're not using to look at what's been done that could inform and give us more evidence when we face a crisis. And now we're at this interesting juncture where we're going from international comparisons not just being a missed opportunity, they're a necessity. The new global challenges, we can't address them with the models of health systems we have. They're not local problems, they're not national problems. Climate change isn't going to go away from the actions of one country, and systems aren't going to adapt without working together. That's true also of pandemics. We need not only to learn from one another, we now need to work together. New systems need to be more cooperative, more global in the solutions that they find. Otherwise, no health system is going to be sustainable. And so I think of international comparisons and the research around comparisons as both this interesting laboratory of being able to learn from one another and collecting the data and mapping the policies to be able to answer those really interesting questions, but also because ultimately we need to change what health systems look like and think beyond these artificial national boundaries if we're going to improve health globally.
All right, so I have like 20 questions, and we're going to go somewhat fast. And I'm going to ask them, and then anybody can take them, and you can all answer them. You don't all have to answer every question. This is a very relaxed panel. Okay, first question. So Martha talked about affordability. We all talk about cost, quality, access. Let's be honest, like the notion of affordability is probably the thing that most people worry about or think about the most. Certainly quality is probably the one policymakers think about the least, but let's talk about affordability and costs. The one thing we know for sure, undoubtedly, is America's got the most expensive health system in the world, right? And even Switzerland, which makes a run for it, is far behind. Like we are in the clear, leading by a lot. What do other countries do to keep their healthcare spending so much lower? I understand that I'm not talking about Kazakhstan or places that are at 3-4%. Love Kazakhstan. Actually, I've never been, but if I had, I know I would love it. But I'm talking about other high-income countries, the Frances, the Germanys, the Switzerlands, which is very expensive, but cheap compared to us. What are the major tools that are in front of us that policymakers in those countries exercise that keep healthcare spending lower? You don't have to name them all. Just give a couple. You want to go first?
Quickly, though.
Take your time.
Okay. I will go for one tool which I think could inform our conversation today. I will talk about budget. So I think that experiences from OECD countries tell us that the budget is one quite powerful tool to keep under control the growth in our spending. This could be translated into different type of policies linked to budgeting tool. For example, the NHS in England gets started with a 5-year plan. So they got a 5-year financial plan, which is used to somehow secure funds for the health sector in England. On that basis, then they roll out an annual budgeting process through which they could secure money on a yearly basis. So I think that budgeting at national level, a budgeting which is comprehensive of almost all the expenses, health expenses by either social insurance, social health insurance, or government schemes. I think it's an important starting point to somehow provide a cap to expenditure, a cap to growth in spending. How does this could work? It depends on the country, on the context, or I would say the history of the countries. So just 2 examples. One is Israel. There are very strict criteria which are used to come up and agree on the budget, health budget for the year T+1 as compared to the base year. Basically, there are 3 criteria which are used by the Ministry of Health and the Ministry of Finance to set the budget for health for the following year. Very explicit criteria, a price index for health, change in the population, the structure of the population, and the third one is how to account for new technology. And so these 3 explicit criteria allows Israel to shift from budget from T to T+1. And they secure funds for the 4 private health insurance which then manage the contract with the providers. Could be hospital, physician, general practitioners, specialists. So I think that this is a good example of explicit criteria which are used to keep health spending growth under control. And then when it comes to the next step, the negotiation in between those four major private health insurance and hospitals, for example, you get reference prices, which are set by law. So you get a regulation of how much you pay a hospital service, normal delivery, appendectomy, and so on. And to guarantee revenue to the hospital, what they have is it's a minimum floor and a maximum ceiling. So the hospital will get at least the minimum floor in terms of revenue from the four main insurers. But if the hospital revenue are over a specific ceiling, then there is a kind of discount to how much is paid each single service. So this is an example of how the different steps of the budgeting process could help somehow containing cost. Second example is France. You mentioned France. It's more a political kind of discussion which takes place every year. There is an expenditure target for health. It's called ONDAM in French, which is agreed on by the parliament. And so each year you got this expenditure target, which is set as a proposal by the Ministry of Health and the Ministry of Finance, is approved by Parliament. And then what you got is kind of alert system. So during the year when you execute the budget, if your budget or the actual spending is 0.5% higher than expected, so the spending objective, then there's a flag. There's a wave to the Parliament saying the budget execution is overspending. Do something. So there are very strict rules in terms of where you are as compared to the budget. I think these are two examples which tell us that a kind of comprehensive amount of money, funds available to finance services you cover through this budget cap, I would say. I think it's quite powerful way to somehow contain the growth in our spending. So my answer would be this could be one tool to think about. Thank you.
So Jonathan. Yeah, so just to agree but also disagree slightly. So I think that budget setting or expenditure targets are obviously like that's the way that European countries keep their expenditure growth more in control, right? Like if you commit that you will only spend Belgium, right? Like you commit to like a growth norm or whatever it's called of 2%, and you stick to it. This is very effective. But I think that the nuance is, do you stick to it, right? So I worked in Finland a number of years ago, and the Ministry of Finance there had this idea that they would stick to a 1% nominal per capita growth rate as part of these huge reforms that they were doing. And ultimately, one of the reasons that the reforms failed was because this was totally unrealistic. This was way too low. So you need to be realistic if you're going to set these targets. Also, they need to be set by consensus, right? You need, if you have sort of a Ministry of Health that has all the power and is setting your growth rate or your expenditure target or budget ceiling or whatever you want to call it, and it's very firm. And providers have a lot of power, like they do in the U.S., and they can just say, "Well, screw you. I'm going to go. I'm not going to, participate in Blue Cross anymore. I'm not going to participate in Aetna anymore, or Medicare or Medicaid." It becomes much harder to do these things. And so, while in countries like France, this is very effective because Parliament gets an alert basically in advance, like, you're growing too fast, and they can step in and do something. In other countries, Ireland has had many times they've had supplemental budgets throughout the year to try and adjust. So you can set a target as low as you want, but if you can't maintain it, if you can't build consensus, if you don't have providers on board, if you don't have Ministry of Finance and Ministry of Health and the insurance fund and the employers, like you need everyone on board with a realistic expenditure target, and then it works. But otherwise, I mean, even in the US, I know that it's changed, but the US has expenditure targets for Medicare, right? Or I remember the sustainable growth rate. Yeah, it was for every year. It was like, great, we're going to control expenditures, and then Congress would override it until it was like ridiculous 20-something% adjustment to physician fees would be necessary to get back in line. So I think like having the consensus, having the guts to make these decisions is also really important. It's not simply make a budget and then walk away. Not that Luca was suggesting that.
No,
but,
and having the guts, but sticking with it. Irene.
So I have something different to add. I agree with budgets and that you need to stick to them. But I think something that Martha mentioned as well is innovation and pharmaceuticals and how these are getting, they're very effective but also very expensive. And other countries, we had heard the example of Ozempic recently, or earlier this year, we did a comparison of a basket of essential medicines that the WHO defines to look at prices across countries and how different they are. And the US pays, I think it's Germany, of the US prices, other countries are paying about a third, a half to a third. These rich OECD countries relative to what the US pays for this essential meds, not the newest meds, the basic meds that everyone should have access to. And also over time, prices in other countries get lower, and in the US they don't. What are other countries doing here? And here I think other countries use evidence much more to negotiate prices. They have health technology assessment. Some countries use comparative effectiveness. Some countries use cost effectiveness tools. They look at relative to existing treatments, what does the evidence say about this new innovation? How effective is it? And they use this evidence to negotiate with pharmaceutical companies and bring prices down. And I think we're seeing some of this being brought into the discussion with the Inflation Reduction Act, but this is a really important tool that is going to be more important that we need to really use and leverage to think about how we make innovation affordable.
Yeah. All right, so we'll talk about health technology assessment in a second. I do want to ask Martha, I know I'm going to torture you. Like the idea of global budgets has been bandied about, and people say, if only we could have a global budget. Global budget's hard. You got Medicare, you got Medicaid, you got private insurers. In a state like Rhode Island, could you envision getting to a global budget where we say, all in, we're going to spend X amount of dollars next year. We'll build in a little flexibility for some new technologies, but we're going to figure out how to hit that target.
Oh, I think it seems pretty far from where we are now. I'll ask the guy from Baltimore, since Maryland's the only place in the country that has it. But to go from a market that's not as evolved on value-based care like we are, all the way to global budget feels like a really hard jump. So I know that we've got interest in the state in doing it, but I feel like the consensus, to your point, John, you need to have. Everybody has to be part of it, and I think it's going to be really hard for the hospitals to say that that's a great idea from where they sit.
All right. Let's talk very specifically about prices, because you brought it up, it's been brought up. And I can't help but think back to the person, at least in the US, I think who taught us more on international comparisons than almost anybody was Uwe Reinhardt, and his classic paper, Is the Price is Stupid, a paper that you essentially replicated and expanded on a couple of years ago. So it's been very clear that we have a price problem in the United States. Our utilization is not out of control compared to other countries. It may be out of control, but so it is in other places. There are lots of countries that have much higher utilization, much higher volumes of doctor visits, hospitalizations, et cetera. What are tools available to deal specifically with prices? And to the extent that it is price setting, is it always happening through governments? Are there any other ways of doing price setting or coming up with lower prices? Or is America doomed to always have high prices? I don't know who wants to start us there.
We have a system, I feel like. We can't change. We'll see what happens.
That's fine. Thank you. I guess if I think about the United States, I think you got all the examples of the importance and the different ways of setting prices you can find across OECD countries, because you got Medicare, which is a classical example of administratively set prices. So there is the purchasing authority which set the price. There's a unit of services for hospital, for example, DRG or whichever version of DRG. You got relative weights, which reflect cost differences across services. And then you got a base rate, which helps you translate the cost weights into a price, which is then used to pay hospitals, for example. And on the other end of the range, you got individual negotiation between private health insurance and a provider, a hospital or a network of providers, where it's very much on, depending on the market power, if I may say, of the two parts. And so you find this kind of range of options across OECD countries. So what I think could be useful is to think about also countries where this price negotiation happens at national level, like Germany, Korea, Japan. So you got a system, you got rules in place for purchaser, which it could be a national health insurance or social health insurance in Korea, or social health insurance in Germany. So there is an annual negotiation in between the different parts. The demand side, the purchaser, and the supply side, the providers, because of market imperfection. So there is no market, there is not an actual transaction in between the buyer and the provider. And so what you do is you set up a process through which you negotiate at country level the price, which could be based on costs. Germany is a good example. You got an organization, a technical organization, INEC, which is responsible for collecting costs at about 300 hospitals across Germany. And so they come up with these cost weights. And then what is negotiated at national level in between health insurers and providers association is the base rate. So how much you pay, the cost weight equal 1. And then you step at the regional level. You got 16 Länders in Germany, for example, where you got a kind of lower and upper bound for the negotiation of this national set price, base price. Usually it's -1 plus 1%, but still there is a negotiation. And so at this level, it's a cost-based price which is used to negotiate in between the different parties. What happens if the parties do not agree? In Korea, for example, but Japan is another example, they sit together and they should take a decision at the end. They sit together in a consensus conference type where you got representative from the government, representative from the purchaser, representative from the providers and the academia, and they should come up with a final decision if the negotiation in between the purchaser and the providers association fails. So somehow, again, it's a political process, but it's based on data, on data collected through technical agencies, which could help really having a kind of reference. Someone calls this a public good, because those price lists could be used not only for transaction between the government, for example, and providers, but also for transaction between private health insurance and private providers. I think the real issue in the United States is price discrimination, I guess. So the variability, the variation you have in prices for the same type of services you purchase from a hospital. I think this is something which we see only in the US, honestly, because other countries avoid this price discrimination by setting prices and using this as a reference. It could be also maximum price, and then you can have negotiation in between the parties, but you get the reference. Here, you don't have any reference, in particular for this private transaction between the private health insurance and the private providers or representative organization of private providers. And I think that's an issue. The second one is how much it costs to manage the system. because all this negotiation, all this different type of setting prices, they have a cost. And what we see in the United States is that more than 7%, we go back to the initial point of us collecting data, so I'm just offering you some data, 77.2% of total health spending in the US goes to administration, so to manage the system. Whereas you got 4% in France, 4.5% in Germany, 3% in Canada. So I think this kind of fragmented system where you find all different type of price setting as an impact, as a consequence in terms of cost too. So I would say there is a lot to be learned, but still, you got good examples in the United States, the Medicare price setting. I think it's a good example of how you could administer prices. So I think that.
But so let me ask a question, because so it sounds like countries do a very different job at price setting, and I agree that price setting in the United States is like insanely complicated and highly inefficient. But I guess question for you, Jonathan, as a policy person, is how do countries get the prices right?
Well, I don't, yeah.
And I actually want you to answer that question in two ways.
Oh, great.
How do they get the absolute prices right?
Yeah.
And then how do they get the relative prices right? Because if you pay twice as much for X versus Y, you're going to get a lot more X than Y.
Yeah.
And so there are two sets of problems with prices. And I think what I've sort of learned is, like, there are lots of bad ways of setting prices. I don't know what a good way to set prices is.
So I don't necessarily have a good way to set prices, but I think the key difference, I guess, between the U.S. and a lot of these countries we're talking about, at least in Europe, is that in Europe, for better or worse, whether the setting of the price is right or not, it's a monopsonist system, right? Whether you have multiple insurers that are following a regulatory framework where they are paying the same prices, or you have a single purchaser that's doing all of the procurement and, you know, of the goods and paying for all of the services. Like, it's not even like there is a right or wrong price. Like, there can be wrong prices, right? You can price something. I know Irini did work ages ago on hip replacements, where prices were sending the wrong signals. But generally speaking, I think in Europe, purchasers are able to get away with paying prices that you probably couldn't get away with paying here. So as a case in point, during the last year or two, obviously there's been huge economy-wide inflation everywhere. And Martha, you were talking, I think, a little bit about the cost of living adjustments that happen to payment rates. In most countries in Europe, there is no automatic adjustment for inflation. Like, you get what you get. And there are other ways that providers can sort of improve their margins if they are a for-profit type of provider, right? Maybe they do some balanced billing in some countries. Again, I'm looking at Belgium only because Astrid's sitting in front of me. But or they can, depending on like the rules about dual practice, they can shift some care private. But generally speaking, like if there's public prices and they're low, like that's it. That's the market. That's what there is. And I think that this is both good and bad. Like from a sustainability, from a financial sustainability perspective, this is good, right? Like if you go back to the previous question about budgets, like you set your budget target at 2%, you contract volumes and you increase volumes a little bit, like you're not leaving a whole lot of space for price growth. So from a sustainability perspective, this is great. From a potentially access or certainly keeping your doctors from like losing their minds, this is not great. So across Europe in the last year or two, there's been doctor strikes and nurses strikes. And so, I mean, it goes back to the same question before, right? If you start doing these things unilaterally, you can do it to a point, but eventually it becomes cumulative and you run out of space to keep putting this downwards pressure on prices, and eventually something has to break. Otherwise, I mean, yeah, like in a place like Rhode Island, this would be impossible, right? You move to Massachusetts if you are a specialist. I mean, I don't know anybody in this room that lives in Massachusetts, but you never know. You know, people have done crazier things, And so I think that yeah, like I think my overall answer to your question is that by having market power, by having it be like the only shop in town is contracting with the compulsory system. I'll say compulsory because it's not always public, but usually public. Yeah, then you can create price. You can put as much downward pressure to a point as you want, as much downward pressure on prices as you want to a point. And when you go too far, you see strikes, you see waiting times, you see dual practice, more private practice. You see providers saying, "I can't treat you here, but if you come to my clinic at 7:30, then I'll see you later," and you pay cash. And I mean, this is not things that just happen in the east of the region. These are things that happen everywhere. So, yeah.
Let me ask, I'll go to Irene in a second, but let me ask a question, in some ways, to all of you. How much variation is there in prices across, let's say, Western European countries? Take a Germany versus the Netherlands. Both of them have, sort of market-based, maybe they're private insurance. Countries are right next to each other. Are there big differences in prices either on a relative or an absolute basis? Yeah, let's say those two, or in general.
I mean, I'll try and answer this, and then I'll give it to you to really
I don't need
answer.
to pick those two if you don't know off the top of your head.
No,
But in general, how much variation is there in prices?
I think that there's not so much variation, but that you see examples where there is clear variation, even if you don't see the price data. So what I mean by that is, if you look, so I did a lot of work in Slovenia, also somewhat random sounding, but not that random. And Slovenian doctors, so Slovenia, if you look very naively at health spending against something like amenable mortality, Slovenia looks amazing. They spend no money and no one dies ever. That's amazing. But if you talk to doctors, it's magic. Yeah, I don't know how they do it. But if you talk to doctors there, they're really annoyed, and so they are. A couple of years ago, I think it was during COVID, Slovenia had the EU presidency, and when countries have the European Union presidency, they kind of like run the show, or sort of they think they do. They try to dictate what the policy agenda is at an EU level. And I was a keynote speaker in this, which I think this was a setup, by the way. I was really unhappy about this, but this was in Slovenia. It was an event talking about sustainability, and it was basically me talking like a silly academic, like, here's some data, let's look at spending across the region. And then it was a panel of doctors who are Slovenian, who moved to other countries and were like, get out while you can, it's much better. We all speak German or Italian or something else. And so I think that there are example countries like Slovenia, Slovakia, for example. I talked about how most countries don't index provider prices or provider reimbursements to consumer prices. Slovakia, they index it to neighboring countries because they're worried about, even though their price levels are lower, they're like, okay, well, if you're Slovakian, you're going to go to Czech Republic, you're going to go to France. So they're very careful. So I think you don't necessarily even need you could be more like a health policy detective and see, okay, which countries do you see much more emigration? Which countries do you see providers are leaving from and going to get a sense of where there are these real price discrepancies.
Right. Irene on this, and then we'll open it up for questions.
Just going to say, we've been doing some work where we look at the same patient essentially and try to understand how their trajectories vary. And one of the things we look at is what is the reimbursement for different types of services. And you see variation. I mean, the U.S. is always the outlier by quite a bit, but you do see variation across some of these other European countries or OECD countries that we look at. You see a lot of variation around drugs, particularly. There's a lot of variation in provider payment, and which isn't always necessarily in the same direction. Like the UK pays generously for specialists, but very poorly for nurses, for example. So differences in inpatient, outpatient reimbursement. So I'd say other countries are consistently lower than the US, but you do have variation across even neighboring European or other high-income countries.
And is your sense that variation drives utilization? That, like, for instance, a country that pays a lot more for specialists, do they get more specialist care?
That's a good question.
You would think you might, right?
Yeah, you would think you might. I mean, and I guess this thinking, I'm trying to think, we've looked at differences in the reimbursement rate for primary care providers and specialists, but Not so much, I guess, at the ratio of that and the ratio of, I mean, but when we do look at this data, the US and I think it's Canada are the two countries that we saw had more specialist visits for certain types of high-cost patients than primary care visits. Everyone else had more primary care visits. So definitely, I'm going to say payment, and I think also supply probably plays into that. We haven't looked at that specifically to really understand the nuance.
All right. Questions from the audience? Did you, oh, Luca, while you're all thinking about your questions, Luca, you want to?
Sure. Just because I'm the data person, I think you need an answer also to the question of comparative price level in health.
Yeah.
We publish some data on this. And I can tell you that, of course, that Netherlands is 2% higher than OECD average in terms of price level for health, 2021. And Germany is 10% lower, and France is about the same. Whereas for the United States and Switzerland, we got 50 to 60% higher price level for health as compared to OECD average. So there's something available which could guide our discussion. So it's just some data, I think, which...
That's helpful. Better to be in the Netherlands than Germany if you're a provider. Maybe. All right. Questions? Patrick Whitney.
Thank you. This is very interesting. So you've got the need for healthcare on a population level, and you've got you guys and others making policies to provide it. Are you keeping up with the change in need and use? Is the process of creating policy happening as quickly as the process of needing better healthcare?
Hard question. Do you want to start it?
I think that intuitively you would think that health status is a major predictor of use and spending, but I mean, it's not that it isn't, but at an aggregate level, it's prices that drive spending, it's supply, it's much more. I would say that that variation in health status is not a major predictor of differences in health spending. Certainly, the U.S. doesn't spend more because everyone is in terrible health. It spends more because prices are higher. It spends more because incentives are out of whack. Like, health status matters, but I think that you would be surprised at how much less it matters than you'd think.
And it gets at the question of like, how much healthcare do people need?
Yeah.
And it turns out there's a lot of variation in what we mean by what is need healthcare. Some things I think we'd all agree, if you've had a heart attack, you need to have that treated. But between that and there's a lot of differences in need. Other questions from the audience? All right, right in front.
I have a good question about transparency and how you feel about transparency. And I'm asking you this question because there's a lot happening with the innovative drugs right now who are very expensive, but there's lots of negotiations happening. And I'm talking this as a Belgian because right now that's hot topic in the news. Apparently over 40% of drug expenditure right now in Belgium is based on drugs that are now reimbursed by means of drug negotiations that happen behind closed doors. So there's no transparency on what the actual initial price was and how it was negotiated down. And this is happening across countries. And as such, we don't actually know if we had a good price or not. And so I'm wondering if this lack of transparency might be driving up the price of innovative drugs as well. And if this system, which is trying to reduce prices, might in itself actually increase prices. And I was wondering how you feel about that.
Yeah, I mean, Ashish put the question to John about, can you define what is a fair price? I mean, I think that it's all about also transparency in the way you come up, you set the price, in the way you engage with the different stakeholders who may be interested in this, the price, in the value you put to a transaction, because it could be to buy a drug or to buy a a service to pay for a service. So I guess there's no specific answer to the fair price, but I'm with you. If you set up a process to be transparent in the way, for example, in the guidelines you use, in the way you come up with a price for a good or a service, I think that could be helpful. When I say price transparency, I mean it's not just a posted price or a list price. It's what actually is paid in these transactions, which is different from what is happening in the US now, if I may say so.
I think I have an unpopular view on this, but
Oh, look, I have
should I have my unpopular view, or you want your more popular view?
I was just gonna, I have just a comment to make here that I think, just to build on this, and you can say your unpopular view, that I think, prices are notoriously hard to compare across countries. We have many comparative papers that conclude that pricing is the problem. We conclude this by not using pricing data, actually, by using utilization data to be like, this is the same, therefore it must be prices, because it's so hard to get prices across countries to compare, because prices in healthcare, because of all the market failures, they're not available, they're not representative, they don't mean the same thing, they're very hard to measure. And the OECD has done, with Eurostat and the World Bank, great work trying to measure prices and healthcare and price levels in healthcare. But, there's no way to compare price growth across countries over time, because the deflators that we use are general economy deflators. So we look at general price growth across countries. We don't even know if health prices, we know they grow faster in the US than general economy prices, but we don't know what that looks like in other countries, and if these policies that we're doing to regulate prices. And so drugs are this one area where we have, I would say, better price information. And it's worse because these list prices increasingly are not reflective of true prices, because we don't have information on discounts, we don't have information on rebates. And I think that transparency does, I would say, I know what you're, it's hard. It's hard to know if you're negotiating a good price, and I think there's negative implications to this. I was talking with somebody from Korea who was saying that China recently started using Korea as one of the countries in their reference pricing, and so now drug companies don't go to Korea before they go to China, because they don't want lower prices in Korea affecting a big market like China, and so. So it's really hard to, and this is going back to what I said earlier, countries need to work together, because these problems, if we work in siloed national ways with national interests at heart, we create these different perverse incentives and secrecy, which I think ultimately harm potentially all systems. But John?
No, I totally agree. And I was going to say, this is not the official line of WHO or the observatory, but I think that, what? Only official lines, not this one, though. Okay. You have countries like Luxembourg and Latvia that are in the EU, and they do not have the same purchasing power. They can't pay the same prices. And I don't think that actually Latvia is better off knowing, if all prices in the EU, let's say for a drug, were transparent, it was all very clear, then I'm not sure that Latvia could afford drugs to pay the prices that Luxembourg is paying. So what I think is a better alternative is building the capacity of countries to be able to negotiate. So building, like health technology assessment, a lot of people sell this as being like this magic bullet for prices. It's not. It's just a tool that helps you to give you a sense of what that right price, let's keep going, there's food out, by the way. What was I saying? Oh yeah. You can build the capacity of countries to do a better job negotiating. I think that probably some sharing of information within countries, and there are networks within country, especially smaller states, where they will share information about the prices that they're paying. And I think this does help their negotiations. But I think that if everything was very, very transparent, there would be winners and losers. And so I think that building the capacity that these smaller countries, smaller health systems that can't really afford to pay higher prices, that they have the tools to negotiate, that they are able to negotiate rebates, or they're able to clawbacks if things don't work, that they have the ability to do these things is better than a single list price like you're buying, like you're going to a restaurant.
Yeah, if I may, let's be pragmatic. There's only one source I am aware of that publishes health prices on an item-by-item basis. So if you want to compare the price of a cholecystectomy in different countries, there's only one source I'm aware of. It's the International Federation of Health Plans, which collects prices at item level for health in, I would say, in a subset of countries, which is chosen just because they're available. So you see the latest report compares Kazakhstan, you mentioned Kazakhstan, to US, to Switzerland, to South Africa. And this is the only source where you can compare how much, what is the price of a cholecystectomy in Kazakhstan as compared to US, as compared to Switzerland, as compared to South Africa. There's only one source. It is a private source. So it's private health plans. You don't find this information available in any other source. We collect those data, but it's not publicly available. We cannot make it publicly available because countries do not allow us to publish data on an item-by-item level. It's hospital services, it's pharmaceutical. We got all this data. We collect all this data. When I mentioned the comparative price level for health, it's based on this item-by-item comparison, but we cannot publish. So when we talk about transparencies, when we talk about coming up with something which could inform the discussion, we need to be also pragmatic. It's not there today. Maybe tomorrow we should work in this direction, but countries are not happy with that. Countries do not want us to do that job as international multilateral organizations. So I think that's a constraint we should be aware of, and how to manage this challenge, I don't know, but still, I think it's an important point.
All right, so it's 6:03, and the only job a moderator actually ever has is to end on time, and I'm 7 minutes. By the way, I got a little run of show, and I was supposed to end at 5:56. Very specific time. I obviously got it wrong. So I'm going to wrap up here, and people are going to mill around, and I think you can ask these guys questions. But I think what we heard today is that the set of issues that Rhode Island is facing, the United States is facing, America does things a little bit differently, but they are issues that every country faces. I actually remember a story when it was about 10 years ago. I was with Bill Shao, who's a great economist at Harvard. I was visiting this rural region of China, and I was speaking to the health governor of this relatively small province of 70 million people in China. And I said to him, what are the major issues you're facing on health in this province? And he said, I think of it in three forms: cost, quality, access. And I was like, you're pulling my leg, because that's what we always say. The point is, rural China, Luxembourg, Latvia, Rhode Island, it's cost, quality, access. But the trade-offs are very different. And you have to sort of keep, in my mind, two sets of principles in your head at the same time, or three maybe. One is there are no simple solutions across these things. If there were simple solutions, countries would have found them. Every country, including ones that we think do a lot better job in lots of areas, are making trade-offs. Sort of point one. Point two is that there's a ton to be learned across countries. I think that is really important. And the third, I'm going to just finish by a story about, again, I mentioned Uwe Reinhardt earlier. It's a very funny story about Uwe. Uwe was a hilarious guy. And in 2016, when Bernie Sanders was running for president, he kept talking about Denmark and how America should be more like Denmark and America should adopt the Danish health system. And so a reporter asked Uwe about the Danish health system and said, what do you think about this idea that Senator Sanders is promoting, that we should adopt the Danish health system? And Uwe, in his very characteristic, very deadpan way, said, look, Denmark is a great system, and I would happily take the Danish health system. But you must also give me the Danish political system, and it would surely help if you gave me the Danish people. And his point was that you cannot divorce the health systems that these folks study and understand deeply, and you cannot understand those things divorced from the political system that oversees those systems. And you certainly cannot understand those systems if you don't understand the aspirations of the people that those health systems serve. So this is really important work. It's really hard work. Personally, I am thrilled that Irene left that terrible London School of Economics where nothing good happens, came across the pond to launch this center. And to both Luca and John, you guys have been great partners for a very long time. Thank you for making the trip to come visit us. Round of applause for the panel.